Good evening, everyone. My name is Jean-Christophe Leroy, and I'm president of the Positive Minders Association. I'm very pleased to welcome you to this event organized by the European Society of Social Psychiatry and hosted by Positive Minders. While we're waiting for the latecomers, would you indicate in the chat room the city and the country you are connecting from? We will start in about 2 minutes. So we've got friends connecting from Paris, from Calgary in Canada, as well as Brussels in Belgium, Strasbourg in France, Grenoble, Bordeaux, Rennes, Brussels, Gembloux in Belgium, San Jose in California in US, Dublin in Ireland, we do stream tonight this event on Zoom, YouTube, Twitter, and Facebook. I think it's time to start now, and I'm very pleased to hand over to Professor François Ferrero. François, I'll let you turn your microphone on. Thank you.
Thank you so much. I'm François Ferrero from Geneva, Switzerland, honorary professor of psychiatry and very much involved in social psychiatry. It is a great pleasure to welcome you for this first webinar organized by the European Society of Social Psychiatry, a still young society founded in Geneva in 2015. The ESSP has the following aims and objectives, among others, only two: to promote mental health through education of health workers and also to the community at large, to promote national and international collaboration among professionals and societies in social psychiatry and related disciplines. Just to say a few words, the first General Assembly was in New Delhi in 2016. The first Congress in Geneva in July 2018. You all understand that after the pandemic and during this pandemic, everything was a catastrophic organization. So we decided to promote these webinars, and the executive committee has proposed Professor Dinesh Bhugra to be the first speaker and to speak on burnout and well-being of medical students and doctors, an international study. It is not easy to present Professor Bhugra. I know him for some years, and probably I would take more than 30 minutes to try to give a resume of his impressive activities. So you have received a short presentation. He has published widely in the field of cultural psychiatry, sexual dysfunction, and service development. He has authored and co-authored over 500 scientific papers, chapters, editorials, and about 40 books. Probably I say 40 books now, but probably it is 41 tomorrow, I'm not sure. Several of his books have won awards and gone into multiple editions. You could discover Dinesh Bhugra in Mandarin, in Japanese, and in many other languages. So he's in so many boards that I will stop here, and it is a great pleasure and great privilege to propose to Dinesh Bhugra to take the floor, if we can say that in a webinar, and to deliver his lectures. Thank you very much, Dinesh.
Thank you very much, Francois, for that lovely introduction. It's a great honor and a privilege to join you this evening. This is evening in Europe, but as we heard earlier, that we've got people from California. So it's good morning there. Can I sort of share screen? Oh. Apologies, I'm just trying to find out what's gone wrong when everything was working fine. Right, here we go. Joys of modern technology. Here we are. Great. What I'm going to do over the next 35 minutes or so is to take you through some basic definitions and issues to do with burnout, both among doctors and medical students, but then I will present some data from the UK largely, but we have done a survey across nations, and I would be presenting that data, and I would really like to acknowledge Dr. Molodynski and his team's contribution to that. I don't have any conflict of interest as far as this talk is concerned. I think just to remind ourselves that when we talk about burnout, it is a pervasive and debilitating state, which results from an unsustainable period of overwhelming stress. And stress is something, situations or events that put pressure on us, times when we have lots to do and think about and don't have much time or much control over what happens, which is often the case in medicine and in other professions as well, but I'm just going to focus pretty well on medicine and what happens to us when we are put under pressure, and individuals have different reactions. So it's an experience of physical, emotional, and mental exhaustion, which is caused by a long-term involvement with situations which are emotionally demanding. So three things happen: that emotional exhaustion, depersonalization, and an absent sense of personal accomplishment. So you keep working, and yet you feel that you have not achieved very much. And I'll come back to that because that's one of the critical issues in medicine, particularly as the practice of medicine is changing. So emotional exhaustion is feeling emotionally overextended, feeling you feel you can't keep up with your relationships and life outside work, accompanied by depersonalization, which is feeling unempathetic, impersonal responses to interactions with patients and their carers. And then that leads to a poor sense of self-accomplishment. And there's a difference between stress and burnout. Stress is about over-engagement, it's about overactive emotions, it's about urgency, hyperactivity, energy, and quite often stress leads to anxiety. Whereas burnout is more about disengagement, blunted emotions, feeling helpless and hopeless and feeling trapped. So you can't really get out of that situation, which affects your motivation and hope, and that leads to detachment and depression. So what makes us ill? Obviously, there are biological, personal factors, but there are clinical issues, there are societal factors, and there's work and environmental factors. And 3 stages of burnout have been described. The first stage is stress arousal, which is typified by difficulty in concentrating, memory lapses, irritability, anxiety, which may be accompanied by physical symptoms of anxiety, poor sleep, palpitations, panic, loss of libido, etc. And the second stage is the period of energy conservation, and maladaptive strategies start to appear, such as avoidance, being late, being socially withdrawn, excessive sick leave. And the final stage is exhaustion, which is associated with anxiety, depression, suicidal ideation, apathy, poor decision making, etc. So what tends to happen is that you disappear, you don't answer your mobile phone, you don't answer your pagers, unexplained absences during the day, frequent sick leave, low work rate, feeling slow in doing any procedures, clerking patients, dictating letters, making decisions, entering data on electronic case records, and then quite often this sense of clinical rage, where there are bursts of temper, shouting matches, reacting badly to real or imagined slights. And that leads to a poor tolerance of ambiguity. And I think one of the big factors in medicine generally, but psychiatry in particular, is dealing with ambiguity, because what the patients tell us, what we understand, what we work with can be very, very different things. And burnout means that quite often people will bypass you if they see either you're not available or you're feeling tired. Colleagues or nurses will find other people to make decisions and kind of bypass you. And then quite often there would be difficulties with exams, particularly postgraduate examinations, uncertainty about career choice, feeling disillusioned with medicine, and failure of insight. And it can lead to medical errors, impaired professionalism, which in turn will reduce patient satisfaction, increases staff turnover, and depression and suicidal ideation. And I'm going to present some major studies, and there's some fascinating findings in this study from Australia that it was noted that symptoms of mental health problems, particularly of depression, were highest during the first postgraduate year. Now, we need to sort of think about that. I mean, particularly, these are very bright, young, enthusiastic, energetic doctors. So what happens in the first year when they start training? And obviously, there are factors like family background, personality traits, stress, perceived overwork, emotional pressure, intensive care setting, and stress outside of work can all contribute. And bearing in mind, this is a web-based survey, and we must remember that a lot of the data that I'm presenting is web-based. So how representative that is of general group of doctors or medical students remains to be seen. But what that highlights is that quite often by clicking on the survey, students and doctors are giving us a message that they are facing problems. So we need to be thinking about how do we deal with that. And they reported high levels of work-related burnout and depressive symptoms. Managing junior doctors to manage their workload was absolutely critical. And nearly a quarter of the doctors in that survey reported having had suicidal thoughts prior to the previous 12 months, and 10% within the previous 12 months, was significantly higher in doctors when compared with general population, almost twice. And that sort of keeps coming back, that in a systematic review, that physicians' relative suicide risk was 1.1 to 3.4 for men and 2.5 to 5.7 for women when compared with general population. Anesthetists, general practitioners, or internists and psychiatrists are at the highest risk. And we can talk about that a bit more. Now, this is about 13 years ago, but 7,900 plus surgeons who were members of American College of Surgeons did participate in an anonymous survey. Although, I mean, you could argue the response rate is 31.7%, which is actually quite good. 6.3% reported suicidal ideation during the previous 12 months, which was much more common in older surgeons. And these were between 1.5 and 3 times higher than the general population. But what is really worrying is that 60% were reluctant to seek help, and 26% of the surgeons who'd had suicidal thoughts had sought help, only 26%. So there are stresses to do with doctoring. There is, particularly when we're looking at both medical students and doctors, that in order to be a good doctor, you need to be able to relate to patients. So you have to have empathy and humanity. And yet, we keep teaching everybody that you need to be professional, which means that you need to keep a distance from the patient and patient's pain and suffering and be detached from it. So we're giving a mixed message here. And obviously, just to remind ourselves, and I'll go into some detail a bit later on, some reasons for burnout are about lack of control over workload, as I've already said, lack of decision or latitude, where ability to make decisions, work is monotonous, and quite often in healthcare, this mundane routine work is interspersed with complex, urgent, emotionally demanding tasks. And there are challenges to do with personalities and financial aspects. So when we look at doctors' health, we're dealing with physical and emotional distress 24/7. So we're giving emotionally all day and night. So who gives to us? And lack of feedback, unless there are complaints. It's very rarely that you get positive feedback. You do get some more in some specialities than others. And quite often this is, working long hours, poor family relationships, work-life balance gets disjointed. And then there are organizational factors, largely politics, both at an institutional level and beyond. And I'll come back to that. So there is this sense of professionalism. You want to be perfect. You need to have a certain degree of obsessionality to make sure that you haven't missed anything, that you've done things right. But what that contrasts with that patient expectations are increasing and changing. And lack of support and praise can affect people sort of feeling valued. And there are clear barriers in help seeking, and I want to come back to that. I mean, there is stigma, particularly if you're feeling burnt out or you're feeling depressed or suicidal ideation. You don't want anybody to know because it could affect your medical license. Regulatory body might throw some challenges in your diagnosis. Quite often the diagnosis is self-made. And we all remember from our medical school days that every time you learned about a new disease, you immediately thought that you had it. But quite often as doctors, we also stop colleagues or friends in the corridor and seek help rather than having a proper consultation. So we did a survey in North India, again in 2008, We used burnout inventory and general health questionnaire 12 version. And the rates of burnout at that time in that sample were less than 2%. So one of the hypotheses that we put forward was that this is because virtually everybody who responded, there were about 300 something doctors in one small industrial town in North India, that everybody was in private practice. So you could control who you saw, how long you worked, how much money you made. And I've known doctors who sort of say, well, this is my monthly income. And once I reach that, I either stop seeing patients or I see patients without any cost. So from 2018 to 2019, I was fortunate enough to be president of the British Medical Association, which has over 150,000 members. And I persuaded, as part of my presidential task, to carry out a survey looking at burnout. So we did use Oldenburg burnout inventory, which assesses only two core dimensions of burnout. One is exhaustion, and the other one is disengagement. And we launched it on World Mental Health Day on 10th of October 2018. The survey was open for about 3 weeks. So we had over 4,300 responses, but 4,300 were usable. A vast majority of doctors, 80%, said that they were at high or very high risk of burnout, with junior doctors most at risk. A quarter reported being diagnosed with a mental health condition at some point in their life, and 7% within the previous year. And 40% reported currently suffering from broader range of psychological and emotional conditions. And those who worked more than 51 hours a week were most likely to say that they were constantly suffering. And this also included medical students, and I want to come back to that. But what was really clear, that 90% of respondents said that their current working, training, or studying environment had contributed to their condition. General practitioners were having problems. But what was really frightening was, although the majority of respondents said they did not use alcohol, drugs, or self-medication, 1 in 3 did. Men and older doctors were much more likely to engage in regular use of alcohol, drugs, self-medication, prescribing to cope with their condition. So subsequently, we then decided that we needed to do a qualitative piece of work to look at in detail what was going on. So from 4,300 respondents, we selected 60 some individuals who were then formed parts of focus groups where we explored what was going on and what was the causation of burnout. So there were these 5 main areas. First and foremost was systemic factors. So there was understaffing, pressure on doctors to fill in rotas, increased blame culture, poor work-life balance, less time available to spend on patient care because a lot of time was spent in filling in forms, trying to find beds for patients, and so on and so forth. And a rotational nature of medical training, that just when you get used to a particular job, it's time to move on. Quite often, some rotations have 4-month placements, others have 6-month placements. So there are different kinds of pressures, and increased paperwork and short time to spend with patients. And then occupational factors were rapidly evolving medical and pharmaceutical landscape, keeping skills up to date. And there were traumatic events, and quite often there was no recognition of impact on individuals when unexpected outcomes happened. And stigma, as I said earlier, but also poor peer support in the workplace, because a lot of work in the UK is done on shifts. So you may not have same colleagues in the same shift that you're doing. And there's a quite clear hierarchy and isolation. Certainly for a very long time, If you were on call on duty, there was no time for breaks to have a cup of coffee or have lunch. Lack of basic amenities. If you were on night on call, quite often you did not have access to food because the hospital canteen would be closed. And quite often people were traveling long distances for work. And there were a few very tragic accidents where junior doctors lost their lives after leaving work because they were feeling tired and driving home. And then socio-cultural factors, the feeling very undervalued by the general public. And as I said earlier, about increasing patient expectations and increasing help from self-diagnosis and Dr. Google. So that, as I said, leads to rigidity, bypass, career problems, etc. I'm just very quickly going to sort of give you findings from the General Medical Council survey. Again, very large numbers, 51,000, nearly 52,000 doctors in training and 20,000 trainers across the UK. And it's the numbers of people who told the GMC survey that they were burnt out because of their work, nearly a quarter of doctors in training and over a fifth of trainers. And almost a third of trainees said that they were often or always exhausted at the thought of another shift. And over a half of trainees and just under a half of trainers felt that they were worn out at the end of their working day. So they felt short of sleep. And intensity of work was heavy or very heavy. And they were constantly working beyond the duty rota and rostered hours. And there were 1/3 of the doctors in training and their trainers said that because of the rota gaps, not having enough doctors filling in rotas, there was a clear loss of training opportunities. And nearly over 1/5 felt short of sleep. Nearly half worked beyond the rostered hours, high, heavy workload, feeling exhausted, particularly among trainees. So 24% of trainees in England, 21% in Northern Ireland, and similar figures in Wales and overall, and similar, I mean, not, look at slight difference, slightly lower, but fairly 1 in 5 trainers who were feeling worn out at the end of the day. And this showed quite a lot of concern. So coming back to the medical student mental health now, I mean, 2 things that we need to bear in mind. One is that we know from epidemiological data from World Mental Health surveys that 3/4 of psychiatric disorders in adulthood start between the age of 17 and 24, and half start below the age of 14. So medical students are at that vulnerable age. And secondly, because of the nature of training, and I'll come back to that, they feel more burnt out. So again, thanks to Dr. Molodynski and his team for the survey we did initially in 12 countries, 3,766 medical students. We used Oldenburg burnout inventory, and we, in addition, used general health questionnaire and CAGE to assess alcohol use. And what is really fascinating is that although you could argue the numbers are quite small in Brazil, the 129, Canada 69, England 84, Hong Kong 123, India is 597, but these were from 4 medical schools, 2 private ones and 2 government ones. But I just want to sort of highlight that this is a screening on GHQ. This is not clinical diagnosis, that 87% students in Hong Kong reported over the cutoff limit. 95% of medical students in Hong Kong were reporting disengagement, and similar figure reporting exhaustion. Canada was lower, and similar findings emerged in other countries, and disengagement is low in Morocco and in New Zealand. But in Portugal, disengagement is very high, and exhaustion 89%, and in Paraguay, 99% of the medical students were reporting exhaustion. So I think we need to be careful in interpreting these findings, because are we measuring the right thing? And if not, what should we be doing? And similarly, when we looked at alcohol, it sort of made very clear that, depending upon countries, there were differences. In India, only 8% were cage positive. In Morocco, not surprisingly, only 5%. But Morocco, 28% had been using cannabis, compared to 3% in Jordan and 21% in Italy. And 35% of medical students in New Zealand were using cannabis, and 79% in Portugal. Now, that may reflect legalization. And so people may be feeling more free to admit that they've been using cannabis. So we just need to bear those kind of social cultural differences in mind. And when we looked at the stressors, there were four. We divided them into four: financial, obviously, related to studies, relationships, and housing. So you can see from this, and I'm not going to go through each country, but just to highlight that in Hong Kong, 98% reported relationship difficulties. Whether that's a cause or a consequence of feeling burnt out needs to be explored further. 59% of students in England complained of housing problems, whereas in Paraguay, only 8% did so. And this is quite interesting because these relationships, all problems also included relationship difficulties with parents. And 18% students in India reported problems with money. 90% in Jordan reported problems with housing. 90% in Morocco reported problems with relationships. So we then, again, thanks to Andrew and his team, we've kind of now gone to another 25 countries to look at similar findings. So these are data from 2021. The earlier data was 2019. So part of the challenge may be, part of the differences may be related to COVID and what happened. And we've seen that very clearly in some countries. Here are the numbers. And what's really fascinating in both this sample and earlier sample, that vast majority of medical students are women. Now that brings about other changes that we need to be thinking about. So males had sort of slightly lower rates of GHQ positivity in India, but disengagement were roughly similar, although men reported 8% more exhaustion. Similar findings from Nepal. Numbers are respectable: 169 students from 2 medical schools. Over 1,000 students from Sri Lanka, with 92% reporting disengagement. Russia, 1/5 of students were using alcohol, but no reported cannabis. So again, we need to interpret these cautiously. So the stressors were identified as increased scholastic workload, competition for scores and exams, because that determines which specialty you get, and high-stake examination. Are there too many tests? And perhaps we can have a discussion about that. And there are other expectations. Clinical years, quite often you get a variable type of patients. you move from, as I said earlier, from rotation to rotation, which may change the degree and the type of supervision. Quite often, teaching makes a difference, poor role models and administrative difficulties. And these are young people. They've left home for the first time. They've lost contact with friends and family. The forming new friendships may be a problem. They may be feeling lonely, and unrealistic expectations. And what is worth bearing in mind, certainly, that when at school or when you were entering the exam, these people are high achievers. But once you reach the medical school, everybody is virtually at the same level. So different kinds of pressures come into play, and that's something that we need to explore in future studies. And I just want to draw your attention to Health Education England report, which has recommended that National Health Service should establish a workforce well-being guardian in every organization, and each workplace needs to have a well-being leader. And this is something that we need to think about, and I'm not going to go through the 33 recommendations, but just to ensure that well-being is on the agenda and being looked at very carefully. And if there are suicides in a student or a member of staff, then these need to be independently examined and reported to the board to see what the lessons are. And NHS must make sure that cultural and spiritual needs of its staff and those learning in the National Health Service are protected with equitable and appropriate well-being support. What we need to bear in mind is that the organizational pressures, and this is again a UK example, but you may be able to apply it to your country and see what these pressures may be. So on top is the government or the funders who dictate to hospitals and primary care what is needed, how it's going to be done, and then you have patients. And then within the healthcare system, you have managers, and then consultants, and then junior doctors, trainees, residents. And as you can see that as far as the pressure is from above to below, you have maximum power at that level, which can lead to coercion and targets and so on and so forth. And here at this level, you are under the maximum pressure, but you have minimum amount of power. So what do we need to do? We need to do three things. We need to look at personal, organizational, and governmental levels. So resilience, and there have been concerns about the definition of resilience, and I'm not going to go into that, but just to highlight that it's individuals' ability to adapt to and manage stress and adversity, facing fear, having a moral compass, religion and spirituality, social support, good role models, cognitive and emotional flexibility, physical fitness, etc. So encouraging self-care and peer support, which is about how do you look after your own mental health and well-being? How do you look after and support your colleagues and friends and peers? And my message to all doctors is that if you're feeling stressed, use your primary care physician before problems arise. Use support organizations. Be very clear about boundaries. Make space for yourself and allow for colleagues. Seek help early. Who do you seek help from? Share problems with family, friends, colleagues. Admit vulnerability. You're human, just like your patients. And certainly about 30 years ago, the National Health Service had a positive discrimination in appointment of certainly psychiatrists who'd had experience of mental illness themselves. That seems to have fallen by the wayside, but that may be something worth thinking about. So identifying and prioritizing activities, having a healthy, balanced lifestyle, sense of humor, regular breaks, emotional intelligence, finding a voice through professional bodies, seeking help early, knowing where to go, having a right mix of interests in your career. And my advice to all residents and trainees who are tuned in or going to be listening, throughout your career, keep a mix of interest. Make sure that you change something in your career every few years to keep yourself fresh. So it could be a mixture of research, clinical teaching, could be management, medical politics, medical writing, entrepreneurial skills. So change something in your job portfolio every few years. Understand your mind, mindfulness training, strengths and weaknesses, develop self-compassion. Who are the people who are going to support you? Look at your lifestyle, look at the sleep. Organizations need to make sure that support avenues are publicized widely. Confidentiality, privacy, and fitness of purpose must be ensured. And certainly in psychotherapy, there would be balanced groups where by discussing patients, people can understand about their feelings of transference and countertransference and understand what makes them tick. After an untoward incident, Schwartz rounds with other members of the team can help recognizing on behalf of the organization and policies and prioritizing issues of well-being among doctors. So we need to think about how medical students are selected, how they're trained. We should not be teaching them training psychiatry in fourth year. We should be teaching them psychiatry from day one. And by teaching them, interaction between mind and body will help. And one of the things that quite often informally medical students have talked to me about is the problems with simulation techniques, particularly when they're seeing simulated patients. They feel that at the back of their mind, they know that such an individual is being paid, he's an actor, so he's not feeling the same kind of pain. So creating an awareness and empathy can be a problem. And multiple mini interviews are used for selection. Are they good? Have they been evaluated? And quite often learning is tick box. Have you attended this course? Yes or no. So there also needs to be a fairly important awareness that medicine is becoming more complex on a daily basis. There are rapid advances in investigations and procedures that we need to be thinking about. So organizations must have wellness programs, better communication about these, trustworthy and confidential monitoring, preventing bullying and harassment, offering coaching and mentorship, moral concerns and open listening. Governments need to make sure that funding is available for well-being of staff and medical students. The resources are available. Proper training is available to individuals who are offering support and who are needing support. And these need to be researched and evaluated. And it is absolutely vital to look after oneself, because if you don't look after yourself, you're not going to be able to look after anyone else. Seek confidential peer support if needed and possible. There's no need to be ashamed. You're human, and this will make you a better doctor. And once again, thank you very much, Francois, for inviting me. And it's a great honor and privilege to join you. These are my contact details. So if anybody needs copies of the slides, or if there are any questions, or if you wish to participate in the survey, please do get in touch. And between Dr. Molodynski and I, we will give you the details to look at the extent of problems in your country or your setting, and how do we take that forward. So thank you so much once again for listening. And I'm happy to take questions or comments. Thank you.
Thank you, Dinesh. It was a wonderful presentation. I received many answers to old questions. I will not take too much time, just to ask you one basic question. I see that you are using the Oldenburg burnout inventory. So Also, Andrew, you decided not to use the MBI. We are reading everywhere. I guess there are good reasons for that. Maybe you could comment after. So
those are financial reasons.
Okay, oh, excellent argument. Yeah, it's
Because,
smaller, for example.
Yeah, and
no 23 or 24 questions.
Meslec want to be paid every time we use their question.
Yeah, you know, it's a business. We know that.
Yeah.
Yeah. Okay. Thank you for the answer. Now we could maybe take some times for a discussion in the panel, but we have to be careful to leave enough time for the general discussion. Andrew, would you like to say something? You are the next to me.
Thank you, and thank you for a great talk, Dinesh. And thank you for inviting us, Francois. And thank you everyone for tuning in, and especially the names that I recognize from people who've been so helpful to us in doing the surveys in Canada, Indonesia, New Zealand, and India. I mean, for me, I think what we've heard highlights the fact that, you know, enough has been done now to demonstrate that there is a problem amongst medical students, amongst doctors of all types and at all levels. And that's not unique to us as a profession, but it is important to us because we are that profession. And I think really we need to move to a much more positive approach of what are we actually going to do about this, and what are we going to ask our health providers and the people who pay for our health providers, what are they going to do about this? Because until now, there's been a very strong focus on individual responses. So, you know, the individual seeking help, which is absolutely right. We all should and must. But, you know, there's not been enough focus on the systems and the pressures that there are on people that are causing them to be stressed, and then causing a proportion of those people to become unwell. So for me, the crucial thing moving forwards is looking at, you know, what are the remedies for this situation?
Yeah, I agree. I mean, I think as I said that there are, you know, three things we need to do at individual, organizational, and governmental levels. But also, to my mind, I think we need to sort of start at a fairly early age. Now, that may be wishful thinking, that we know that 50% of psychiatric disorders in adulthood start below the age of 15. So we should be going to schools to work with teachers and with students to look after themselves. And one of the things that really sort of intrigues me, particularly in this country, that there's a lot of human capital. Lots of people have retired and lots of people have time on their hands. So we should be using their skills in developing education and developing awareness. You know, the challenge, for example, making sure that, you know, people have physical exercise and cognitive exercise, and making sure that they eat properly. And, you know, so how do we look after our own mental health being? Maybe we need to lead by example. François?
Yeah. Thank you. I will come back after the discussion with some more personal questions, if you agree. I would like to ask Luigi maybe to give a brief comment.
Thank you very much, Francois, for your invitation. And this is very proud to stay here for the first ESSSP seminar or webinar. And I think I don't want to believe that this is a substitute way instead of Congress. And I wish that we will be able to meet all together in an open way, stay in presence. And Dinesh, congratulations for your brilliant and comprehensive lecture about a theme that is crucial for because it deals with education and assistance in the area of health promotion and protection. Namely, is a key element of the civilization process of any society. I would like just to, because when I heard your the matter of the issues of your presentation, the idea came to me to think about the problems that doctors and students in medicine could have met in this era of COVID-19 pandemics. So this is because I just read something about this and this argument, and we know that because in addition, for example, speaking about physicians, and I read that in addition to known reasons for burnout, and you was speaking about burnout very exhaustive way. In addition to known reasons for burnout, there are other additional identified factors, such as, for example, lack of control over procedures, inadequate protective personal equipments, lack of preparedness and emotional support, and poor communication and directives. So there are also many psychopathological conditions that may derive from that and may follow the direct exposure, for example, to dying patients, such as PTSD, obviously. And among the possible resources could be cited, for example, telemedicine, telepsychiatry, and also one of the main objective could be to implement the mental health quality and wellness level by, for example, psychological instruments. I would cite, for example, mindfulness, but also psychotherapists and anyway counseling. Also in the cases of medical students, COVID-19 outbreak has posed very important problems. For example, digital learning in medical students carries significant risks because they have observed a decrease in mental health in the case of online lesson, and also a decrease in the quality of learning, obviously. Students also reported a decline in their, this is an USA study, also reported a decline in their overall wellness during COVID-19 in at least 8 dimensions: intellectual, emotional, physical, social, occupational, financial, environmental, spiritual, and so on. So in the just to end, in the COVID-19 pandemic era, medical students are more lonely, more isolated, staying too much at home. They feel more heavily over their heads and their shoulders the pressures of competition and expectations from the others, also from family, obviously. And also, the learning is worsened by the distance and from clinical practice. And psychopathological consequences include usually depression, apathy, and anxiety, panic attacks. There is an overlapping between psychopathological consequences and burnout syndromes that you have highlighted before: substance and alcohol abuse, emotional dysregulation, impaired impulse control, and so on. So I would like to know, to ask you, what if you have, what do you think about these problems, and how to implement resources and aids to overcome this problem?
That's a very good point. I mean, one of the things that, as you were speaking, was going through my mind. We've had a couple of studies from Guatemala, again, comparing pre and post COVID. So it's not only in a kind of American rich country issue, it's similar problems are emerging. The rates have really shot up. But the other interesting thing that I hadn't thought of was the pressure on teachers, switching from face-to-face teaching to online teaching. And the stress in them has gone up as well, because you need to be technically aware and savvy, and you need to prepare everything in a way that, like when we started and I was kind of trying to share screen and find my slides and getting lost in that. So certainly pandemic has created major problems, both for students and teachers, in terms of isolation, in terms of loneliness, in terms of different ways of learning and different ways of teaching, and not having that face-to-face contact with patients, for example, to understand what the patients are going through. So one of the challenges for all of us is to find, I very much hope that of the people who tuned in or who would be listening, if you know of examples of good clinical practice, it'll be really worth sharing that so that we can learn from each other rather than reinventing the wheel. And obviously, as you say, Luigi, mindfulness is important. Can we, train everybody to develop those skills? Should we be forcing everybody to go for a run or do physical exercise or do something else? So it is that there are things that we can recommend to people, but we can't force them to do certain things. So if we're using, and increasingly, I think the virus is not going to go away rapidly. It will be with us for some considerable period. So how do we find examples of good practice in teaching and learning and examining that we can share across, modified according to local cultural needs, local resources, to try and, so that's where the organizational and governmental involvement comes in. And we have to come at it from all those three levels.
Thank you, Luigi. Thank you, Dinesh, for your answer. May I ask to Alexandre to deliver some good words?
Yes, of course. Thank you very much for the invitation, and thank you for the very comprehensive talk. Maybe I can comment on three aspects about the emotional load that medical doctors and students have to face. I wanted to comment on the dimension of empathy and whether it's whether empathy is a good or a bad thing to protect ourselves in this kind of job. And I think there is no simple answer to this question. And we just started a study with medical students and recruited about 1,000 medical students that will follow exactly to see in more details whether there are differences between students who show more empathy and or lower empathy scores, and whether they will be more or less at risk. And I think it's important in this investigation to differentiate several dimensions of empathy, because empathy can be seen as one thing or a more complex framework. And I think more comprehensively, interpersonal competence is very important with respect to how we will experience exhaustion, emotional exhaustion, or not. So we'll see what are the results, but I think really it's a complex issue, and maybe it's also a dimension where we can, of course, I don't think we can teach a certain way to be empathic, but we can reflect on what it means to be empathic, and how we can kind of regulate our engagement with the patients. So that's the first point. The second point is about the residents, the very early career residents who are especially at risk. And I've read some work that I find interesting, more qualitative works, about the fact that, for instance, very early, first-year residents, for instance, actually don't see the patients as their main focus, but they rather see their supervisor as their main focus. And because really they have to kind of please the supervisor, and it's kind of interfering with the way they can really meet with the patients. And so I think this is also maybe a point where something can be done in terms of supervision. As supervisor, we should really think about that and see how we can supervise in a way that it's not leading to burnout, for instance. And the third point is about access to care, because it was really well shown that doctors are not seeking help in a large proportion of cases. So how can we improve that? That's one point. At Lausanne University in Switzerland, where I'm serving, we tried to facilitate access for the medical students. And indeed, we have a fair number of students that seek help, psychological or psychiatric help. But I guess there is a lot to do to facilitate also access to help when it's needed. So.
Thank you, Alexandre. I guess time is now to open the discussion. If you agree, we will come back with other comments later on. And so, Jean-Christophe, are you organizing that part of the discussion? Or?
Yeah, sure. No problem at all. We've got a couple of questions from the public, and one of them is, what about the actual role of the well-being guardian, and what could be the future of this mission?
I think that it's a recommendation from Health Education England. It hasn't been accepted fully by every hospital in the country. But what it suggests, to my mind, I mean, certainly one of the big changes in this country had been, and Andrew may be able to give a bit more up-to-date information, is that hospitals used to have access to occupational medicine, occupational health physicians who attended regularly. So the staff knew which day of the week they would be, and how accessible, whether they needed to book an appointment or could they just drop in. That changed a few years ago, and a lot of these services were privatized. So some services and some hospitals are much better than others. But the point that I'm making is that if there is somebody, one person responsible for staff well-being in the hospital, then he or she can take control and take charge of services, development of services, access to services, and also to try and make sure that enough resources are dedicated, rather than it getting lost in the managerialism or in the system. So that's one advantage. And the other advantage is that if things go wrong, then somebody takes responsibility, and that would be such a guardian. But one of the things that, going back to what point we need to bear in mind is that quite often in hospitals, medical students are seen as a burden. They are not part of the team. They don't feel part of the team. They're just saying, oh, you know, on top of doing this, I have to teach them and do that. So there's more pressure, not only on supervisors and trainers to do that, but also on medical students to make sure that they don't get in the way of clinical practice while they're learning. So those kind of tensions need to be resolved. And maybe, you know, having one person, a well-being guardian or somebody who's responsible for mental health of, you know, staff or students can then take on that responsibility.
Thank you, Dinesh. Somebody else want to?
Andrew, do you want to sort of comment?
No, I agree with all of what's been said. And I think some organisations, I think in many countries, do things very well, don't they? And do take a great interest and provide good pastoral care, and other equivalent institutions, frankly, don't. And one of the things I think that, you know, people on a national or a regional level can do is to try and develop some kind of charter or set of minimum standards that can be used both to help institutions that are not doing so well to get better and to hold them to account, but also to acknowledge, congratulate, and possibly reward organisations that are doing well. So in the UK, we had an interesting thing with junior doctors, so trainee doctors, that trusts who could meet certain fairly basic criteria about the arrangements they made for trainees to have rest and food and recuperation were actually given a sum of money. Not an awful lot of money in our context, but, you know, several tens of thousands of pounds. And it was amazing how quickly all the NHS providers signed up to the scheme and were, broadly speaking, successful in getting the money, which was then used for better resources for trainees. And, you know, maybe we should be thinking along similar lines for, you know, all medical staff and medical students as a way of leveraging change.
I think one of the big messages from the BMA survey was that somehow medical students were better served in terms of seeking help than junior doctors were. So there is that tension between different groups, and it'll also be interesting to see whether different specialities deal with it. I mean, as psychiatrists, we should be better at responding and dealing with it and helping people. But, you know, that's a very kind of personal view.
There's also a very interesting question about the quality of work or the impact of burnout on the quality of work for doctors and students.
Yeah, I mean, I think that's you know, the point that I was making in my presentation was that quite often people withdraw. So, you know, you can't be found, you're not part of the team, you may come late to the clinic, and when you come to the clinic, you may shout at the receptionist or start shouting at the relatives who are demanding, who've been waiting for a long time. So those kind of consequences of burnout need to be dealt with before they become consequences. So, you know, we need to be preventing the possibility. So educating, training, supporting, giving right information is absolutely crucial.
Another question is on actually the diagnostic of burnout, and as you mentioned that it says auto-diagnostic in your statistics, but what makes the difference between a burnout and a manic attack or a classical delusion, Prof?
I think there are both similarities and differences. If we look at burnout, I mean, one could argue that it's trendy to have burnout rather than have depression, because depression has a different kind of stigma. And one of the things that we need to bear in mind is that burnout is related directly to work and the circumstances in which you are under pressure. You're under so much pressure that you can't deliver your best, that there is pressure to do that. And we need to, I mean, I was kind of really intrigued by the study where Alexandre was talking about empathy measurements, because I think that's going to be really taking us one step forward as to which dimensions of empathy are affected more than others. And if so, how do we look at the doctor-patient interaction, doctor-patient relationship, the therapeutic alliance that we form, and how do we work on that?
We do have another question about, in fact, I'm wondering if a person could ask the question directly. This is Norman Sartorius asking the question. Many of the findings you describe are worrisome, but what about other young people? Do they have more burnout than medical students? Young lawyers or engineers feel better?
I think the only study that I'm aware of from the same university, there was one in Wales and one in Guatemala, and both showed that the rates among medical students were higher compared to lawyers or pharmacists or other health professionals. So again, I mean, I think it'll be certainly worth exploring that further. And if people listening in want to compare medical students in their medical schools with other disciplines, nursing, occupational therapy, psychology, I would be very happy to work with them to take that one step further.
May I add something? I remember a paper in the Harvard Business Review in 2018 saying that some people extremely gifted were subject to burnout. And they called that, if my memory is correct, the malediction of talent. But I don't have numbers. So
I think, you're right. I mean, definitions do matter. And that also allows people to seek help or not, or withdraw completely and say, I'm not going to see anyone. So it's absolutely critical that, we don't jump into this game of medicalizing everything, but being very careful as to, what are the consequences. And we need to look at the consequences of creating new diagnostic categories.
Just to comment, it is not the case at the moment. It is not recognized as a diagnostic category.
No, but I think the danger is that quite often, you would know from general tendency, if you look at the size of ICD-11 or size of DSM-5 compared to DSM-1 or 2, so what has changed? And, Norman led on ICD-9 and 10, and, it's probably one of the most sort of culturally sensitive diagnostic system. And I saw a question from Chris in Canada, I think, looking at the sort of cultural differences in burnout. And I think that's absolutely vital, because the financial pressures, and as it showed in medical students, the financial pressure versus housing versus relationships versus academics, so that they are different. And by and large, the curricula for medical students is roughly similar globally. There might be some specific cultural differences. So what's going on? And I think that's where all of us need to come together to think about ways forward.
A little look in a crystal ball for all of you. With the succession of COVID waves, do you foresee a degradation of mental health for doctors and future doctors?
Do you want me to have a go, or shall we get the panel to comment and then I'll come in? Young.
Let's start with Andrew, for example.
Good luck, Andrew.
I think Andrew's frozen.
Yes, Andrew is frozen.
Luigi, do you want to take it?
Let's go to Luigi then.
No, I read that. Yes, I read that there was a worsening of mental health due to the pandemic spread, and this was amazing for many of us to understand that there is a risk of this worsening of mental health. I was very impressed by the fact that the information that psychiatrists are at particular risk for suicide, and I knew that, but when I heard that from Dinesh, I was additionally more impressed. Okay. But anyway, I don't know, because suicide is also another problem in after COVID. But anyway, is also independent from COVID. I would say that I don't know, but because do you think this is a question also to Dinesh? Do you think that, for example, suicide is in this category at risk of specialty, of medical specialties, such as psychiatrists, is that as a final stage of the burnout syndrome, or is it independent from burnout? And what do you think is possible to do with this problem? Do you think that there is a more structured intervention to do for decreasing this suicidal risk, or we have also to foresee, for example, psychotherapy for psychiatrists? I think is not amendable, but also for other specialties, specific pathways to protect them from the suicide risk.
I think certainly the observation has been the rates are high among anesthetists, largely because they have access to more potent substances. For psychiatrists and general practitioners, I think it's also to do with a number of factors, whether it is to pressure of work or other reasons. And again, access to medication or ways of performing the act differ, and there are again cultural and gender differences that we need to be thinking about. But one of the strategies that we have used in this country, and certainly British Medical Association needs to be commended, is that there are various services. For example, there is a 24/7 helpline that anybody, whether you're a member of the British Medical Association or not, you can ring, and you couldn't be counseled. Then there are face-to-face counseling available. There are within that, there are challenges related to, for example, problems with the General Medical Council. So BMA has a separate service providing input to doctors who may be struggling with that. BMA, along with Royal Medical Benevolent Fund, has funds available which may be given to people who may be feeling stressed because of financial problems and financial difficulties, not being able to pay their mortgage or whatever. And then there is a charity jointly funded, which is called Doc Health, which provides face-to-face counseling, 6 sessions or up to 12 sessions. And now recently we've introduced group sessions. I chair the board of that charity, but what that sort of indicates is that what we need to be also aware of is that one size does not fit all. Different people have different needs, different pressures. And as a profession, we have a moral and ethical responsibility to go as far out as we possibly can to support our colleagues and peers who need help.
Okay. Thank you.
For the time being, I don't have more questions. Yes, one is coming. So are doctors more at risk of stigmatization in case of mental disorder, more at risk to be discarded from their work?
I think there is a fear, not only of stigma about having mental illness, because doctors are supposed to be competent and self-sufficient and really powerful people. So to acknowledge that you may be feeling below par can be, shatters your self-image and perception, but it's also to do with acknowledging one's vulnerabilities. Whether doctors have more stigma, I don't know. Norman may be able to comment on that. But to my mind, I think the fear is more to do with what the regulator would do. And I would lose my livelihood and I wouldn't be able to, feed my children and do things. And having reached that level of achievement and suddenly to be taken away can be really scary. So again, one of the, as I sort of presented, this is an annual survey carried out by the General Medical Council. So they are aware. So working between different bodies. So for example, Royal College of Psychiatrists here runs a service which is for, again, online by phone for psychiatrists who may be struggling, working between British Medical Association, Royal College of Psychiatrists and General Medical Council. There's a wellbeing network. So again, it's something that each country and each nation need to think about what would work for them to make sure that we can offer help for people who are under pressure, people who are feeling suicidal and who are feeling vulnerable.
François, I do hand over to you.
Thank you. So I was thinking about so many questions and other themes we could address. Thanks to you and thanks to this burnout problem. Time is now at the end of this webinar. I would like to thank warmly Dinesh for his wonderful presentation, my colleagues from the panel. The panel is too short, but we decided to distribute the active roles in the future, and we hope with Luigi and with Yasser to organize many other webinars like that. And maybe you know that we will have another one next week, next Friday, with Professor Michaela Hammering on trialogue, recovery, human rights, etc. Very important too. For this first webinar, it's a pleasure to see that people are active, that the level is so excellent, that we are very well supported by Jean-Christophe and by his team. And I would like to thank all of you, and of course also all the participants. They are not anonymous, but we are not saying them. And I hope we will be much happy to be together next Friday. Thank you very much to all of you, and I hope you will be safe. Take care.
Thank you.
Thank you
very much.
Yes,
Yeah,
wonderful. Miracle.
Bye.
Bye-bye.
Thank you very much, all of you.
Thank you.
Very much.
Thank you.
Bye.
Thank you, Dinesh.